Okay, so our poster is about whether panic attack training should be included in the preclinical requirements. So this kind of came from having personally witnessed a patient experiencing a panic attack in the dental chair, and realizing that I wasn't properly trained to handle that situation. It kind of made me think about maybe this should be something that should be implemented. So for the problem for our research, where it kind of started was panic disorders are one of the most prevalent mental health disorders in the United States, with the dental anxiety and dental phobia being one of the most prevalent issues in dental practices. Like it affects 10 to 20% of adults and as many as 43% of children and adolescents. So the purpose of this was to assess the dental providers' comfort levels, and whether training should be implemented if they feel like that would help them. And this would kind of be as part of before you start clinic, you take different emergency trainings and things to prepare you for treating patients. And while we have other trainings with different things like if someone, has blood sugar levels go low or different things, we were never trained about if someone has a panic attack. So whether they feel like that would be necessary and if that they feel they need those skills to effectively manage that emergency in a clinic. So how we put it together was we did an anonymous survey, and participation was completely voluntary. We used a sample from junior and senior dental hygiene students, as well as junior and senior dental students, as these are the students that see the most patients right now, would have the most experience. And we used descriptive statistics when analyzing the data. And yeah, I'll let Angelina take over.
All right, so I'm going to go straight into the data and the results of what we found. So, as you can see, if you look at some of these charts in the middle, it basically explains what we looked for in our survey. So we asked the students to tell us about themselves, and then we asked how much training they feel like they have and if they're confident in their training. We asked about if they are able to identify signs and symptoms regarding panic attacks. And then we were asking if the students agree or believe that a uh, like a course on panic attack should be required prior to entering clinic, and if they feel like it's important for providers to even um, have knowledge on the topic of panic attacks. And lastly, we asked if any of them had any experience with patients who had panic attacks. So if I would direct your eyes to the right side of the screen where it says results, I'm going to go over some of the results with you. It says 30%, 37% of students knew the signs and symptoms of panic attacks. 16% of students felt like they had enough training, and 95% of students believe that it's important for dental providers to be knowledgeable on panic attacks, and 82% of the students believe that school should incorporate this course as a clinic requirement. I also want to highlight, so in our survey, we had a portion in our survey that where students could write in a response and type in their experience. So I really want to highlight these two that some of the students shared with us. So for the first one, it says um, they experienced a panic attack with, so, oh, sorry, the student said, I experienced a panic attack with my patient in clinic. If faculty was not there, it would have been very challenging to deal with alone because I was not educated on proper protocol. So that really shows that some of the students, we're taught these skills to, you know, the sorry, like the clinical skills. We know how to do the procedures and stuff, but sometimes students don't necessarily understand how to manage the patient's emotions. So that's what this quote highlights. And our next quote says, I treated a patient who had a panic attack in the chair. They had a bad prior dental experience. And I just want to emphasize that we didn't put in the quote, but they said it's been about like 8 years, I think, since they had the bad experience. And then they said they appeared fine during EIOE and probing. I began scaling and they started gasping for air and I almost choked. Their hands were tense and they started shaking. They raised their left hand, which was still shaking as the indication for me to stop. or they were uncomfortable. The patient left early. So this also shows how intense it can be for the patient. And sometimes when our patients are panicking, it puts panic in us. So that's why we believe that this training should be implemented um, in events like this. So in conclusion, many students don't feel confident in their knowledge of being able to even identify the onset of panic attacks. Many students do not feel they have enough training on that topic, and most students believe that this knowledge is important to have. Most students also agree that the school should incorporate a course on panic attacks. And as Chevy said, it wouldn't be like an additional like actual course, like it would be like a module that you have to go through or some videos that you have to go through in order to prepare you for clinic. Just like we do like infection control videos or something like that. This would be something in addition to those requirements. We did have some limitations as there was not much time to collect data, which impacted how many responses we had. But even with the limited responses, we can see how important it is to have this training and how um, many people don't have like the knowledge or the protocol to manage panic attacks. And in the future, if we were to get more results and everything, what would be important is to assess how students would like to receive this information when they're being taught, whether it be via modules, videos, PowerPoints, or all the above, maybe some role play. So that would be future steps. But all in all, our poster was just to highlight that as students as well, that we may not feel prepared for situations that are so spontaneous and that maybe trainings could be implemented in the school. Do you have anything else to share, Chevy? Do you want to share your experience and what kind of inspired this?
So I know I shared that a little bit, but hold on a second, I don't know if you can see the poster. Um, Okay, there. But yeah, I personally experienced a patient who had a panic attack and I just didn't know where like what to do when it happened. And I also, at least there were faculty there who kind of knew and like told us what to do. But that was kind of what started this because having other training in other areas and knowing what to do in other emergency circumstances, this one just came out of nowhere and I didn't even know what to expect it. That it was just as a practitioner, I think I could have done better in that situation and helped the patient more. And then when the patient returned the second time, I was a lot more prepared and knew what to do because I looked into it and did my own research. So I just from that, I felt, this is something like, why do we not have training on this? Obviously, it happens, and I must have not been the only one to have experienced it. So I just kind of started questioning maybe this is something that should be implemented. And as we saw from the results, many students felt the same way. Majority honestly feel the same way. So it was just cool to see how from that experience, we could see some change maybe. And yeah, I think that's it, unless anyone has any questions.
Yeah, thanks.
Hello, everyone. My name is Bahar Ademoglu, and the title of my research is called Implementing QR Code-Based Diabetes Risk Assessment in Dental Practices, a pilot study on evaluating effectiveness and acceptability in dental settings. Before I go on to explaining what my research is about, I just want to let you all know that I just recently got the IRB approval last week, so I started to implement this study like 3 days ago. As a result, there is no data collection and it is still in progress, but I will walk you through the purpose, the methods, and the anticipated outcomes of my study. Before providing the background information, I'd like to explain why I chose to conduct research on this particular topic. My study addresses an important public health issue, which is undiagnosed diabetes. Currently, a significant number of population in the US is unaware of their diabetes or prediabetes status. And just to give you some context, over 1 in 3 Americans have prediabetes and 90% are unaware of their condition. So, and for those who are diagnosed and receiving treatment, it costs the US healthcare system nearly $413 billion. $413 billion, let that sink in a little bit. These numbers, to me, not only shocking, but deeply concerning. And if no action is taken, this growing crisis could eventually bankrupt our healthcare system. So this is one reason why I chose this topic for my research. What is particularly relevant to us in dentistry is the well-established bidirectional relationship between periodontal disease and type 2 diabetes. About 50% of the adults in the US, 30 or older, are affected by periodontal disease. And if both conditions exist and not addressed, meaning, if you have periodontal disease and it's untreated, and if you have diabetes and it's not controlled, they can exacerbate each other, creating a cycle that worsens the patient's outcomes. And because people often visit their dentist more than their physicians, dentists can play a crucial role in identifying patients who may be at risk for diabetes and facilitate early intervention. However, while diabetes screening is well within the scope of practice of dental providers, a valid and reliable screening tools are available for dental providers at dental settings. It has not been adopted routinely by the dentist for some reason. And one of the biggest barriers to implementing routine diabetes screening is found to be the time constraints and workflow limitations for the dental providers. And to this date, there is no model that exists to integrate diabetes screening into routine dental visits. So I wanted to address this issue by integrating a quick and simple risk assessment tool into the dental offices. And to address this, I chose a method of displaying this, and here's my flyer right here, displaying a QR code on a flyer in the waiting rooms of the dental clinics. And patients can simply scan the QR code and complete a validated risk assessment that is straight from the American Diabetes Association, and find out about their risk levels. And for those who are found to be high risk, they will be encouraged to follow up with their primary care provider for further testing upon completing their survey. I'm also providing information about diabetes from the American Diabetes Association if they're found at high risk. So using this approach, we hope to raise awareness about patients' risk level without disrupting the dental workflow. I'm also testing the feasibility and acceptability of this method by the dental providers. So at the conclusion of my study, which will take about 4 to 6 weeks, these participating dentists and office personnel will be receiving a brief survey to assess their experience. Ultimately, what I want to know is whether this method is practical for both patients and dental providers, and whether it can help awareness of diabetes risk among patients. So as for the methodology, I'm conducting a mixed method cross-sectional study using a convenience sampling. Our participants include dental providers, administrative staff, and patients, obviously. And I am using Qualtrics to create surveys with both closed and open-ended questions. And the analysis will have both quantitative and qualitative data with feedback from all stakeholders to assess the effectiveness and acceptability. And for the results, as I mentioned earlier, I just began implementing our intervention, so there is no data to share. However, I anticipate that our method will effectively overcome time constraints in dental settings. and I expect to receive positive feedback regarding its ease of use and integration into existing workflow. For the discussion part, the primary hypothesis is that the QR code tool will effectively overcome time constraints in dental settings. Again, we expect to receive positive feedback regarding the tool's ease of use. We're also realistic about potential challenges that we may see while during this implementation phase, such as patient engagement. That could be a significant consideration. Patients may choose not to use the tool due to maybe they have limited technological knowledge that could prevent them accessing the survey, or they could just have concerns about privacy. They may feel that the surveys are going to be asking personal information, which is not the case at all. They may also feel that they're not even interested in finding out their risk levels, or they may not even notice the flyers that are sitting, standing on the desks. So if they're not engaged, obviously this could potentially affect my this intervention. And for the provider's perspective, there could be also resistance to change as well. And they may find it that's not even useful, or the front desk staff might be reluctant to make patients aware of the flyers. They may be shy about, discussing the patients or talking about, or they may be even too busy to discuss with patients. So all these could be possible challenges that could arise during the implementation phase. So to conclude, the study explores a simple and yet hopefully impactful way to bridge the gap between dentistry and medicine. Ultimately, I hope that this research will contribute to a larger conversation about integrating diabetes screening into dental care. And that will conclude my study. Thank you so much.
Okay. Hello, good morning. My name is Arabuman Agbonhese.
And my name is Stephanie Benitez, and our project is assessing community health workers' oral health training to improve community health worker medical dental education. And we also want to say thank you to our mentor.
All right, so community healthcare workers, they're basically healthcare professionals who link individuals from underserved communities to medical services. So they go out into communities that are in rural environments or with underserved communities, and they kind of help link them to medical services, dental services, and other healthcare services that they need to improve their health. And they also kind of help them navigate the healthcare delivery system. But unfortunately, oral health is often overlooked and not included in the community healthcare worker training program. So to address this gap, we developed and held 3 virtual oral health training courses. The one that we're going to talk about today is the one that we held November 1st, 2024 for the community healthcare workers from the Eastern and Western Shore area health education centers. And this course was to help enhance their knowledge and skills on oral health so that they feel more confident promoting better oral health in these underserved communities.
All right, now we're going to get into the objectives, and I'm just going to take it back to the training Nancy was talking about. So after the November 1st training, during the training, we had like an open question at the end, and we asked a few questions, and it left us thinking because a lot of the community healthcare workers said that they would have like different type of information. So then that kind of got me and Nancy rolling with this. And we kind of hypothesized that the patient population does determine the type of information that the community healthcare worker needed, but we wanted to further investigate it and prove it through this poster. So basically the purpose of this study was to gather feedback from the community health workers who have previously completed the course to determine whether the community healthcare workers value oral health integrated into their service. And we also wanted to determine what additional information would make the oral health training more comprehensive in terms of their specific patient population.
So to complete this research, the methodology we used was an 8-question quality improvement survey, and we sent this to the participants who joined the November 1st training. And the survey was distributed by email through the executive directors of the Eastern and Western Shore AHEC. And the survey was sent to the participants 6 months after the November 1st training to help assess their integration of oral health promotion recommendations and also their dental Medicaid information into the community healthcare worker services. And the survey questions, they were written to identify which specific concepts from the training were applied, as well as gather insight on additional oral health information that could enhance their service delivery. So to kind of summarize all our results, we used descriptive statistics to illustrate the percentage of participants who felt that they benefited from the survey. And IRB did determine this project to be non-human research on February 13th, 2025.
All right, and now getting into some of the data and the results that we got back. So to start, the survey was sent to the 46 community healthcare workers that attended the training on November 1st. And then from those 46, we had 19 people respond to us and give us feedback. So one of the questions we asked them was, on a scale of 1 to 5, how confident do you feel discussing oral health with your patients or clients? 1 being not confident at all, and then 5 being very confident. And then as we can see in the pie chart, the purple represents very confident, number 5. And 58% of them did respond that they felt very confident after that first training in providing, oral health information. 16% responded with a number 4, which was still pretty good. And then about 28% responded with a number 3, which is like they were kind of in between, kind of felt okay about it, maybe still had some doubts. But overall, more than half of them did respond that they did feel confident delivering oral health information after the first training. And then another question we asked them with the pie chart below is, if they did use the resources that we gave them, then we asked them to share what information they had been sharing with their patients or clients. And the 2 biggest sections in the pie chart, I guess you could call it, was the kind of pinkish tannish one. It was the best brushing techniques. They really liked that. And then they also apparently distributed a lot of information about preventative dental care. And then another one, the green one, as you can see, is also pretty big. That one was finding a dentist nearby. But basically what these results were showing us is that different community healthcare workers shared different information. And like we hypothesized, this probably was because they were all working in different communities, different populations, and different types of patients. So everyone needed something different from the other.
To touch on what Stephanie said, we asked 2 questions. The first question being, what patient/client population do you work with most often? And the second question being, what additional oral health information or resources would be most helpful in your role? So one thing we can see with these 2 questions is that there's a positive relationship. And a positive relationship meaning that as one increases, the other increases as well. So for example, and I know this is a lot, so I'm going to use my mouse to kind of highlight what I'm specifically talking about in each pie graph. So for example, in the first question, you can see that 7 of the participants mentioned that pregnant and postpartum individuals is the patient population that they work with. And the positive relationship you can see is down here. 9 of the community healthcare workers mentioned that pregnancy and oral health is additional oral health information that they would like to receive. Another thing we can see is in the additional oral health information, 13 of the community healthcare workers mentioned that they would like to hear things about oral health and chronic illnesses, examples being diabetes, heart disease, etc. And you can see right here, people with chronic conditions, we have 12 of the community healthcare workers saying that that is the patient population and the clients that they work with. So you can see a positive relationship between the patient population that they work with and the additional oral health information that they would like to receive.
All right. And basically, in conclusion, we came to the conclusion that our results did indicate that the health education is highly valuable for the community health workers, as many of them did utilize the trainings that they received to support their patients. In addition to that, after the first training, the community healthcare workers also did request funds so that they could integrate oral health into their program, and they also did receive those funds. So that also supported our hypothesis that, that they did find oral health information very valuable, and that it should be integrated into their program. But to continue, our findings also suggest that the location and setting play a crucial role in the delivery of oral health information, and understanding the specific needs of the patient population and in the environment in which care is provided helps determine the most relevant and effective information to share, ensuring that oral health interventions are tailored to the unique context of each community.
Thank you so much.
Right, so this study focuses on the possibility of bringing mental health screenings into dental settings. And to give a little bit of background, depression is a leading cause of disability not in the United States, but worldwide. On an annual basis, it costs the global economy about $1 trillion in loss of productivity, and it can result in various other issues, such as substance abuse, self-harm, lack of self-care, and unemployment. With these individuals living with mental health conditions, they have a 40% higher risk of developing systemic diseases such as cardiovascular disease, metabolic conditions such as diabetes compared to the general population. And we know that these two conditions have a link to periodontal disease. There have been some studies that have shown that there are higher rates of dental decay and tooth loss compared to patients without mental conditions in comparison to the general population. And it's something for us to think about because patients see their dentist or dental provider every 6 months, while patients are seeing their primary care physician once annually. With the population seeing their dental professionals more frequently than their primary care providers, dental settings can serve as alternative settings for mental health screenings, which could result in earlier identification for those in need of further assessment and care. So the objective and purpose of the study was to gain insight on patient acceptance of receiving mental health screenings in dental settings. In terms of method, this research study obtained IRB approval March 25th of 2025. It is a cross-sectional exploratory study, and there is no sample size yet because we still are in the process of obtaining data and participation. But for those who do participate, there is a 10-question survey, and in that survey, it asks demographic questions about the patient as well as questions asking about acceptance of mental health screenings in dental settings. Later on, once that data is obtained, we'll use descriptive statistics. So if we look at the middle of the poster here, we see a sample mental health screening. And for the research in the survey, patients aren't expected to answer either of these questions. It's just provided so they have an idea of what a mental health screening would look like, giving them an idea of the type of questions that would be asked of them in this dental setting if they were to have them. So the first question asks if you've had little interest or pleasure in doing things, and you rate it from not at all, several days, more than half the days, or nearly every day of the week. And the second question was feeling down, depressed, or hopeless. So it's just 2 questions. It's pretty quick mental health screening. Once the data is obtained, some of the demographic questions that we will have addressed include age, gender, what dental clinic they came from, and their appointment type. In the data, we ask if, one, they think that it is appropriate to incorporate into a dental setting, and 2, if they'd even be willing to incorporate it. Because some people may think both are appropriate and willing to do, or no for both, or some may think it's appropriate, but it's not something that they may be willing to do. So that'll be an interesting thing to look at. In the end, we want to see if they think it's appropriate, if they'd be willing, and some challenges that we may experience. include patients who are reluctant for something like this due to stigma around mental health. You know, some people may feel uncomfortable discussing their mental health in a dental setting due to societal stigma. There are some relevancy concerns. Some patients may not understand, or maybe even providers may not understand whether mental health screenings belong in dental settings. And time constraints, that's another big thing. Dental appointments are already time sensitive as it is, and adding screenings, it could potentially feel like a burden to patients or to providers. But we don't know any of that yet. We are waiting on our data, and that is all. Thank you.
Okay, so for our presentation, we decided to explore the impact of loop selection on provider well-being and musculoskeletal strain. So as you all know, buying loops is a big milestone for students. It's exciting, but it's also expensive and it can be really overwhelming, especially when purchased so early into one's dental career, usually in the first year of school with really little training. And I know that personally speaking, when I purchased my own pair of loops, I felt really dissatisfied with the experience, and I wanted to see if other students felt the same way.
Piggyback with Samantha said, I also felt that purchasing loops very soon, as early in the semester wasn't the right decision for me to purchase, without having, more experience and study that could help me to decide what kind of loops that will best fit for my fit.
And I know that it seems obvious that loops help prevent musculoskeletal disorders, but there really is a lot more that goes into it than just wearing a pair. There's factors like magnification, declination angle, and fit. They all play a huge role when looking for a product that will actually reduce strain. And I think that the problem is that students often have to make this decision with just very little guidance and education, and they may end up with an expensive pair of loops that don't actually serve them in the long run. And loops make our lives easier as providers. They make things brighter, more clear, but they also play a really important role in our health and protecting us from musculoskeletal disorders, which led us to really want to explore this issue and find out how students feel about this topic, because I think that it's often overlooked and a lot more important than people may think.
Okay, so when we go to methodology, we gather data, we walk to their clinic, recruiting patients using a Qualtrics QR code. In just about short period of time, it was about 3 days of data collection, and then we were able to receive 66 responses, with only one person declined to participate. This strong interest suggests that the topic is highly relevant to students, and we should further explore, and possibly it will help to develop a guide for the loop selections for these students.
So our survey was made up of participants of dental students, dental residents, dental hygiene students, and like as Mina said, we surveyed 66 of them, and we had responses. And the largest amount of responses were from the fourth year dental students, and they composed 33% of all responses. And most responses were satisfied with their loops. That was 70% of responses, but nearly half of responses said that they do experience musculoskeletal pain occasionally, and that was at 47%. So I know it's a lot of numbers, but based on the results, the biggest influence of loop purchase was also peer recommendations, which was 58%. And that was followed by cost and overall comfort. And the main factors that were considered before purchasing were magnification, fit, and adjustability. And among the 55% of participants wanting to change their loops, common requests were wanting better ergonomics, wireless lights, and overall improved comfort around sensitive areas like pressure points.
So to discuss this topic, even though most students said that they were happy with their loops, but most of the half still wanted some changes with it. Picking the right pair can be overwhelming sometimes, but especially with having so much little guidance. Peer recommendation were the biggest influence, like about 58%, as Samantha have mentioned earlier. But that doesn't mean always that whatever worked for your peer will always work for you. Even though 70% were satisfied, almost half of them reported that there were some musculoskeletal pain, and 55% have wished that their loops were more comfortable. So participants were saying they are satisfied by the number of them that will make changes. That really shows that there is a need for better guidance so students can choose loops that actually helps them in the long run.
So our conclusion was that our results, it showed that the topic is worth exploring because many students still experience pain or they feel that their loops can be improved. And it's also important to note that students are in clinic, but we don't see that many patients a day. Usually the most is 2, and we don't have clinic every single day. So if you're already experiencing musculoskeletal pain with the limited amount that you're kind of spending in clinic, it's not going to compare to working like a full day for 20 years. So that's just something to keep in mind. And the study also highlights just there should be a need for more guidance when selecting loops. And like nearly half participants reported musculoskeletal pain and many wanting adjustments. So we felt that it's clear that the selection process isn't really working for everyone. And we wanted to just test the waters and see if this topic was worth exploring. And based on our data, we see that it is something that participants and students are feeling passionate about, and we think that it can be looked into more deeply. And our findings, they could act as like a foundation to creating a more tailored guide to help students with making informed choices that will hopefully prioritize comfort, ergonomics, and long-term health. Because right now, with like the way that it's set up with purchasing loops, it's kind of hard to navigate all those things, especially with dealing with different vendors and scheduling when we're busy students. And there's just a lot that goes into it. So having some type of guide that could come out of this study would be very helpful, I think.
Thank you so much.
Okay, hello. My name is Gabrielle Coltrane, and my title is Enhancing Dental Hygiene Students' Learning Outcomes with Nearpod Technology. So just as a result, my IRB did get approved on February 28th of 2025. So this study has not underwent implementation just yet, but will occur later in this month, followed by data analysis. So what we're really going to be going over today is the methodology of what is to be enforced later this month, plus background and literature review on how this topic kind of arose and the importance of it, especially when you're talking about the application in a professional education setting, which traditionally employs a more of a passive style of learning. So to add further context, we have seen an exponential growth in online learning, especially in the past 5 years, which has been both convenient for the learner as well as the educator, as it has made learning more convenient as well as accessible, but it has also challenged the manner in which people are presenting their material and educational standards. So this is where you have seen interactive educational tools, with Nearpod being an example of an interactive educational tool, which is a platform that takes traditional PowerPoint or Google Slides and takes that static information you see, we're going slide to slide, and makes it more dynamic for both the student and the educator, as the student can interact with the slides, do problem solving, all applied when you are in the learning process. So it moves from a more teacher-centered approach with passive learning, which is traditionally seen in professional education settings, to a more active style of learning where the student is the main driver in their educational process. So, sorry. The use of Nearpod technology originally came from my sister, who is an educator, and she is a fourth grade teacher in that sense. So I thought about the application that it would have in a professional education setting, being that you see fourth graders who are 9 years old learning in this type of setting, especially in a younger generation where we know that they were employed during COVID-19 because of online learning. So traditionally, we hope that these platforms can help with lectures by making it more dynamic in the experience, as it's appealing to your auditory sense, where you can listen to videos, interact with visual and sensory information, where you can problem solve all at once, and it provides feedback to your teacher at the same time. So it's like a double standard or bi-directional of education to both informing the learner as well as the educator. So Research to determine the effectiveness of Nearpod in dental school cohorts has been observed, as we'll see later in the literature review, but it really hasn't been observed that much within dental hygiene education, which is the main focus of this presentation, particularly in a dental hygiene class of 15. Nevertheless, that's why we're doing this, to see the efficacy, especially with learning outcomes using retrospective data compared to the previous class that employed a more traditional learning perspective with just PowerPoint slides to a more interactive platform. So for more background on how this has been conducted in other types of settings, it has been done in a dental school setting, which is similar to how my project's going to be conducted. It particularly concerning the topic to be covered is the caries process. So there was a 2020 study, but it was over the 5 weeks, which our implementation will happen in a single day in a couple weeks. This was 5 weeks caries process in first-year dental students, and the evaluation that came from it was that it can be effective in education for both memory and long-term goals and establishing mastery of dentistry topics. So that's really the goal of the outcome of this study, is that you hope to see mastery of topics, especially and particularly in dental hygiene cases as it could be applied. And it also has been studied in different approaches such as pharmacology, so across the biological spectrum. So it exemplifies that what I talked about, the active learning style, and is capable of engaging students in their lecture, either self-paced or taught at the teacher's pace, where you're learning within the classroom, but you can also learn on your own time and practice on your own time, opposed to going home from a passive learning lecture and having to reteach yourself or relearn the information that you just went over. So it's productive and saving you time in your educational process, but then also it's effective in making the most utilization of your time while you're in the classroom and getting the most out of your educational experience in that case. So the methodology, the participants will consent to a survey. So we're going to be collecting both qualitative and quantitative data by examining their overall learning outcomes, which will be conducted in the form of an assessment that's not actually a part of the research, but more observational in case, and seeing how this class's test scores have changed or altered from the previous classes that didn't employ an active learning or Nearpod technology-based learning. So we're going to get their perspectives in the qualitative point of view by seeing their perspectives on the tool and the content delivery, if it's user-friendly, if they like it, and so on. And the research team will compare it retrospectively to their test outcomes from last time. So they'll be given the same test from the previous year and seeing how those students in this cohort tested compared to previous students that didn't employ it. So it is a study of convenience, which can elicit some type of bias, but overall you hypothesize that the students in this cohort will have improved learning outcomes compared to previous cohorts or the previous dental hygiene class. So it's not yet implemented, so we don't have results or a general conclusion, but overall we hope to see improvements and hope that students will be honest and do like the online learning platform and would like to see it more in terms of their professional education and more student-centered learning compared to what is traditionally applied. So that's the real conclusion of it. And then we will know the results sometime in August. So that's my presentation.